I have the pleasure of reintroducing our speaker from last week. Monica Roberts is an academic detailing pharmacist with the Healing Community Study. Prior to joining UK, she participated in community pharmacy and completed residency training with UK and Kroger Pharmacy. She's certified to initiate the dispensing of naloxone per protocol. In addition to her PharmD from UK, she holds a BA in newspaper journalism and psychology from Syracuse University. Welcome back, Dr. Roberts.
Thanks, John. Yep, I'm back. I'm going to share my screen. I do not have any new financial relationships to disclose since last week, unfortunately. Our practice gap and learning objectives are going to be pretty much the same. We're talking about naloxone, trying to make sure everybody sort of up to speed on naloxone and how we can help save lives and prevent death from opioid overdose. We have some review slides that I am going to skip right over and jump into the questions. If there are any topics from last week that you have additional questions on, or you want me to go over again, something that didn't make sense, please feel free to throw those in the chat or just speak up at any time. We have a few questions already in the queue, but we'll certainly be able to take other questions as needed. So I am also planning to hopefully have a lot of you participate. This last week or so has been just an onslaught of presentations for me, and we have reached to the point where I am sick of hearing my own voice. My husband does not believe that's possible, but I would like to hear from other people for at least most of this hour. So we'll dive in with the first set of questions. I'm so glad somebody asked, what is the process for setting up a Nalox-box or naloxone vending machine? And kind of asking what would we need to do if we wanted to have one, and what are the differences kind of between these two concepts. So we didn't talk about this. We talked about it right at the end last week, but I didn't include it in the initial didactic presentation just because we had so much other stuff. So I'm glad I get a chance to kind of tell you a little bit about this. I have a picture here of examples of each of these. So on the left is a Nalox-box. Nalox-box is the brand of this particular box. These are also called opioid rescue kits or overdose emergency kits. Basically, they look like a first aid kit, and we put them in places where we expect overdoses to happen, where we want people to have quick access to a dose to administer to somebody who's having an overdose. So these are often paired with AEDs or first aid kits, and they look like a first aid kit, right? Some of the brands sell them with like a break glass kind of setup. Some of them are just unlatch it and open it up. But it's just one dose of naloxone, usually a CPR mask and some instructions in a little kit where somebody can use it. The other kind of idea for immediate access naloxone is this vending machine concept. And you can see this looks just like a vending machine that would have soda or candy or whatever in it. But instead of food or drink, it has naloxone. And the idea here is to create sort of a 24-hour semi-anonymous access point where people can go and get a box of naloxone to take home and have and carry with them. This one has naloxone, and I actually don't know what is at the bottom down here, but these vending machines in other states often have harm reduction supplies. So somebody asked if they were fentanyl test strips. They may well be. There are even states where they're putting syringes in these, or packages that have syringes and alcohol swabs and other harm reduction tools that people can select which product they want. In fact, in one of these that I've seen, the kits are kind of all identical with just different colors and labels on them, so that somebody could go and get what they needed without anybody really knowing what they were picking. Here in Kentucky, it's a little more complicated to do other supplies in these, particularly syringes, because of the way our syringe service laws are written. But we have recently been told that naloxone vending machines are something that are legal to do, and we're starting to see these pop up in some places around Kentucky. In terms of installing one or implementing one in your organization, there's several things that you're going to want to think about before you kind of do this. The first is, what is the purpose of this? So I talked about that a second ago. Are we looking for immediate access for administration or kind of a distribution model? The next question is, where can you put this? So obviously the vending machine is going to take up a little bit more space, but is also maybe temperature controlled, so it could go outside. The Nalox-boxes need to be somewhere appropriate, but also sort of protected. You don't want them out in the elements. The other thing to think about with location is security. Naloxone, unfortunately, is not cheap. So if you're filling a vending machine up with, 50 doses of naloxone, you're talking about a few $1,000s worth of naloxone. If it's in a place where one person can come and hit that button 50 times and take it all, you're going to have to refill it every, week or every day. That's going to get really expensive really quickly. So a lot of times they recommend putting this outside the health department or in a law enforcement facility, say people getting out of jail, where it's somewhat observed, but also somewhat private. The next thing you would think about is products. So both which naloxone products do you want to put in there, as well as what tools do you want to use. So vending machines are made in all sorts of sizes and shapes and manufacturers. You would need to work with the manufacturer to make sure that those boxes fit in the coils. The Nalox-boxes, like I said, there's different formats of them. It's all kind of the same concept, but there are different manufacturers of them. The three big things here down at the bottom are going to be, how are you going to fund this, and what are the ongoing costs going to be? So the Nalox-boxes, the brand ones, cost around $300, and that's just for the box. So you have to supply the naloxone, the CPR mask, whatever else you want in there. And then obviously if it gets used, you have to replace the dose that gets used. So you would need an ongoing funding source for that one dose or couple doses that you're going to put in there. The vending machine, obviously much more expensive. They're going to range in the thousands of dollars. And then you're filling it with a lot more naloxone. So you're going to need an ongoing source of funding for that. The Healing Community study right now has a process for Nalox-boxes. We do not have a process for vending machines at this time, but there are other grants and other programs in Kentucky that are doing vending machines. We also are just now starting to get into that opioid abatement money, and people putting in grants for that money. And so that is an opportunity potentially for a place for funding for these vending machines. The last two things are kind of the same for any naloxone program. You're going to need a supply of naloxone. So you're going to either need to work with a pharmacy or a provider who can order naloxone to supply whichever unit you're using. And then you need to make sure that you have a way to do overdose education. So remember, the law in Kentucky says you can pass out naloxone, but it has to be to persons who have been trained on the mechanism and circumstances of its administration. This is all it says. So for pharmacists, if they're doing that naloxone dispensing, they have to do verbal and written counseling. But for harm reduction programs, the law is silent on the format, the content. They just say people have to be trained on the mechanism and circumstances of its administration. So I know some places that have vending machines have gotten vending machines with a screen in them where it plays a training video constantly so that the person at the vending machine can be trained in that way. People have made the argument that you could just include training on paper in with the naloxone. That's going to be what is acceptable is going to be up to probably the person that is supplying your naloxone, what they're comfortable with and what they think is going to meet their requirement under the law. So that is something to think about. I would say the Nalox box barrier in terms of overdose education is probably a little bit lower since it's really just there for that immediate need. It's one dose. I think you could make the argument that if you trained the people who were working in the facility in naloxone, that could be sufficient for sticking that thing on the wall in the facility and having it available. But definitely for the vending machine, if you're handing out naloxone in large quantities, I think I would want to be able to point to something and say, this is the education that we did. So I'm going to stop talking and look at the chat. I know Shirley is at a site that has a vending machine, so I would love if she would chime in and talk a little bit about what they do and how it's going while I look for the other questions here.
Okay, so we've had the machine for a minute, but we went through Core and ordered the supplies and stuff, and it's real simple as far as it's just like any other vending machine. I've stocked it in there and you just hit the number you want and it comes out. And I asked the officers this morning, has anybody used it that's been released? And he said there's been a few people to take it. What we did was we took the flyers that gives the education on how to use it. And then when you open the box, it has directions as far as how to use it as well. So there's the education portion of it. And there was going to be a tablet at the top playing, showing how to use the naloxone and stuff. So it's so far so good. People are utilizing it. Of course, our lobby is shut down. It's closed.
Oh.
So it's not open to the public. So we don't have to worry about it being abused in that sense that, but so far so good. People are interested in it and it's fairly easy to stock. Actually, when I ordered the Narcan, it came within just a few days. Like they had the shipment here and it's all a real simple process.
That's awesome. So I'm glad to hear it's going well. So it is Narcan specifically, the brand that you guys stock in there?
Yes, actually, It's the nasal spray. If you can see that, that's what we have in there. I would love to be able to do the fentanyl test strips as well at some point, because I think that's vital as well. I kind of have mixed feelings on that because even if they test it and they know there's fentanyl in it, they're probably still going to use it. So I don't know. It could go either way with that. So.
Yeah, and that's another area where I think we're still catching up in Kentucky with what the legislation says and, how legal is it to pass those kinds of things out.
Right.
I think we've made good progress on naloxone, and hopefully if we can prove that this model of distribution works, we can start sticking some other stuff in there.
Right. I agree. It's a process, but I'm just happy we're where we are because unfortunately, some people that come in here don't want help, and we find out that they've passed away or they've had another near fatal overdose, or or they end up right back in here for the same behaviors. So, but at least they're armed now and they can protect themselves.
Yeah, that's awesome. Thank you for so much for sharing. Sorry for just calling on you at random. Let's see, I'm looking at the other questions. There was a question about, has there been consideration for putting these in airports and bus stations? Yeah, I think there's talk about that for now. I think the goal is to get them kind of where you're going to get high risk people because of the expense of it. My belief is that especially if it's free, a lot of times you're going to have those things get emptied really quickly in a high traffic area. Potentially by people that aren't really the highest risk folks. So it's sort of that balance between how do we get this out there without how do we create this like massive amount of waste and doses that are just going to be sitting in somebody's closet or expiring or whatever. There was a story from Vine Grove, and I think it's in Hardin County. I could be wrong about that. They had a big splash when they got their vending machine installed. It was outside the health department, I believe. And then 36 hours later, it was empty. So there was this whole discussion about, was this a good thing because people heard about it and each person came and got one dose, or did somebody come and take it all? The Healing Community Study did a learning collaborative on this very topic a few months ago now. And some of the programs from other states that talked about what they did said they had a registration process where you either went online or you came to the health department and you registered and got like a card that would let you go get supplies and naloxone and all those things out of the vending machine. So it was more of a 24-hour access for syringe service participants than it was just like a general public distribution type thing. So there's lots of different models for it. Heather says they have a vending machine at Madison County and getting ready to stock it. That's exciting. And Whitney says more access to fentanyl test strips. Yeah, that, like I said, that is something that I think is coming, but they're still trying to figure out how to do it. Sometimes we have to, when we first start these harm reduction efforts, we have to get a little creative with what the legislation says to be able to do it effectively. And yeah, bus stations would be a good place. And these are places, bus stations and airports, that would be great for a Nalox box, right? Put it next to the AED or the first aid kit. And then people who are experiencing overdoses on site would have naloxone there available. So any other questions or comments about either of these? I don't know if do we have anybody here from HCS who could talk about Nalox-boxes? HCS has installed over 100 Nalox-boxes now in the Wave 1 counties. And people seem pretty excited about those. UK in particular, they have put them all over campus, which is exciting because they were slow to get on the naloxone bandwagon, and now they have them in most of the buildings that they own. So that's a great opportunity on a college campus to have naloxone available for administration everywhere. The next question is, how can a group of people get trained on naloxone? Is there a way for an organization to quickly get a large group trained? And can an organization host a training or have training at an event? The answer here is yes. There are lots of ways for an organization to get a large group trained. Again, you're going to need to find somebody that can do the training and somebody that can supply the naloxone. So if you're in a healing community study county, that is probably our prevention specialist team. Do we have anybody from the prevention specialist team here? I'm looking at the participant list. I don't see any of them. But those are our healing community study staffers who can go out with our naloxone supplies and do these trainings for groups of people. If you were not in a healing community study area, or you didn't want to have a prevention specialist come, I would say, calling a local pharmacy that has a protocol in place and seeing if they would be willing, the pharmacist would be willing to do it. Looking at the local harm reduction organizations, places like Voices of Hope often have opportunities to do this. And then, yes, absolutely, hosting a training or having a training at an event. A lot of these harm reduction organizations or the healing community study will often be available to set up a table and just train anybody who walks up. The health departments also sometimes do this depending on their supply and their staffing. So that would also be a good place to call if you were trying to set this up. Does anybody else have any ideas on this? Anybody who knows of an organization or works with an organization that does this?
I only just had a question. I don't
Yeah.
know who would be the best partners, but you talked about college campuses, but also thinking about just teachers and high school teachers. Are they being trained to know how to identify and administer this?
Yeah, they would be a great population to train. I know we've had some interest from some schools. There is some weird policy stuff with school districts. Sometimes they push back and say we don't we don't want the teachers to have it because it's a prescription medication and they're not supposed to have that in their classrooms or that kind of thing. So it's probably not, there's not an organized program to get teachers, and there's not like a mandate from the school districts or from the state to try to make sure that schools are equipped with naloxone. And even some of our higher education colleges and universities in Kentucky have a little bit of stigma, I think, still, and have said like, oh, this doesn't happen on our campus, which would be hard to believe. So that there are certainly opportunities out in, if they're at a public event or something, for them to do it as individuals, but I don't know that there's any specific effort to get them kind of in a structural way trained and educated. But I know we would love to do it if we could get permission. And then Whitney asks about law enforcement. Again, this is kind of hit or miss. This is a high priority for when we talk to our community coalitions, that almost always the coalitions say, we want law enforcement trained, we want them carrying naloxone, even sometimes we want them distributing naloxone. But we see varying levels of engagement with law enforcement. So some law enforcement agencies are like right on board, they're first in line, ready to go. And then others still kind of don't want to deal with it or don't see it as their part of their mission, and are a little slower to pick up on this type of training. But I think it's getting better. I feel like it's getting better. That's a question later we can talk a little bit more about. Any other thoughts on this or questions on this? Yeah, Amy says corrections officers in the jails. And that was something that came up in wave one. We were trying to get the jails to distribute naloxone to the people that were being discharged. And eventually some of the jails came back and said, can we have some naloxone to keep on site? Because we want to have it in case of emergency here in the jail. And so we did have an opportunity to get that happening in some of the jails in wave one, which again was a great example of, you sort of change hearts and minds. You see it working on the distribution side, and then all of a sudden people say, oh, this is something we need too. Are there studies showing the impact of leave behind naloxone? So in this case, I'm going to assume that leave behind naloxone is referring to EMS and like fire departments handing out doses of naloxone at the site of an overdose. If that's not what the person who submitted this question meant, feel free to correct me, but I will talk about that briefly. There are not a ton of studies. This is kind of a growing trend. Oops. We do have one study, and if I can manage my computer here, I will put the reference in the chat. So this is the reference for this study that I'm showing here. And then there is one other study from San Francisco. I don't know how helpful it is, but it was a small survey of emergency medical providers, service providers' attitudes about doing this, which I found interesting. But this one study that we have is from a leave behind program in Howard County, Maryland. If you're familiar with Maryland, this is Columbia, Maryland. So kind of suburban Baltimore plus sort of a little bit of rural area. And they had a partnership between their fire and rescue team and their health department. And so the fire and rescue had naloxone, and they would offer it to individuals at the scene of an overdose. They would also collect information about the person who overdosed and give that information to the health department to follow up with contact from a peer recovery support specialist. So they wrote this paper about the first 238 overdose calls that they had this program running. 120 naloxone kits were accepted. About half of the time it was given to a family member. And then regardless of whether the kit was accepted or not, they attempted to connect the person to peer support. And they had 143 successful attempts to connect patients or they had 143 attempts to connect patients to peer support. They found that if the family member took naloxone, it was 5 times more likely that they would successfully connect the person to peer support. About 4 times more likely if a friend took it, and then about 2.5 times more likely if the naloxone was given directly, was accepted directly by the patient. So there's a lot of sort of debate here about what is the cause and effect. But I think it is safe to say that in this instance, if there were concerns about naloxone reducing the likelihood that somebody was going to call for help or get additional help in terms of treatment and that kind of thing, that was not the case. Accepting the naloxone was not like, oh, good, now I don't need to call EMS ever again, or now I don't need to deal with anybody. If anything, having the naloxone kit really helped connect people into services. So that is the one study that we found. I did a literature search this week, and I asked my colleague, Dr. Doug Euler, who is also deep in this area, if he knew of any studies, and he said this was the only one he had ever seen. So if you're involved with EMS and you're interested in publishing on this topic, that sounds like there's a good opportunity here. I can say anecdotally from our wave 1 programs where we started Leave Behind, we heard a lot of positive feedback from the fire departments and the EMS folks that had it. They said they felt like just being able to offer something tangible to help the person survive was a way to reach people that they didn't have before. Like it was opening doors to conversations that they weren't having before they had the Leave Behind program. So does anybody here participate in a Leave Behind program or know any more about Leave Behind programs? They are an option in the kind of strategy selection process for the Healing Community Study. So we might see more of them pop up in our wave 2 communities. They are, I think, a great opportunity to reach high-risk folks with naloxone. Obviously, we know having one overdose is a huge risk factor for having another one. So,
Monica, I have a quick question. So with
Yeah.
those Leave Behind, is there any kind of like literature requirement or training requirement as part of that, or is it just leave and follow the directions? Or
yeah, so it is kind of the same as any other harm reduction distribution program. They are supposed to train the individuals that they leave it with. I think that's often a very quick, here's naloxone, this will help reverse an overdose the next time, here's how you use it. Because obviously EMS is there for the purpose of getting the patient to the hospital and dealing with the overdose. But there is definitely some element of training. And I think there is probably an element of the people at the scene of an overdose are very receptive and probably very familiar with what is going on because they've just experienced this emergency. Given the prevalence of fentanyl, how much naloxone do I need? We hear stories of people needing 4 to 6 doses of Narcan to reverse an overdose. How much should I have? And it seems like new naloxone brands are increasing, not necessarily the potency, but the dose. Is this in response to fentanyl? So we talked about this a little bit last week. This is a big open question in the world right now. We have 3 naloxone products. We've got our 4 milligram Narcan and generics of Narcan, our 8 milligram Kloxxado, and our 5 milligram Zimhigh. And Kloxxado and Zimhigh definitely used fentanyl as their reason for creating these products and for submitting their applications to the FDA. The FDA has pointed to approval of these products as part of their efforts to address the fentanyl problem. The drug companies have definitely leaned in to fentanyl as a reason to use their products over other products. I won't show it because it's a little disturbing, but the Zimhigh folks have really gone with some like dark marketing about, like you need the highest dose available to save lives. If you go to their website, it's they're not shy about saying like, this is what you need to save people. That all said, we don't have great data that shows these doses are needed to reverse fentanyl. We did not have evidence that naloxone or that Narcan in the 4 milligram dose was not sufficient. We know that people are giving more of it, but we don't know if that means they don't have that people, we don't know that people are dying because people don't have enough naloxone. There is some argument that fentanyl, because it gets into the brain so fast and works so rapidly, and because the potency of fentanyl and fentanyl analogs in the drug supply right now is so high, that in some cases where naloxone is not working, it is because no dose of naloxone would work. The overdose is happening too fast for naloxone and too strong for the naloxone to get in there and bump the opioids off the receptors. There is also a lot of debate in the harm reduction community about the issue of acute severe withdrawal. So the more naloxone you give, the more likely you're going to cause withdrawal. And there are some very loud voices in the harm reduction community that say we should not be using high doses of naloxone and causing everybody that we reverse to go into withdrawal, because then people are not going to want to use naloxone. That there will be people will wait too long to give naloxone because they are afraid of the outcome of severe acute withdrawal. I don't have a good answer for that. I think it comes down to personal choice. Outside of the healing community study, several folks at UK and CORE conducted a study at the state fair this year, where we made a video that went through overdose response and all 3 products and very briefly compared, this is the highest dose, this is the lowest dose, this is what withdrawal is. These are the available products. And then we let each person who watched the video select which product they wanted to take home with them, and did a survey on why they were choosing that product and what they were considering. And I will say, we don't have all the data processed and everything yet, but we were surprised at how evenly this distributed out. We thought nobody would want Zimhigh. It's an injectable, it's a super high dose, that people would lean towards the nasal sprays just for ease of use and safety. And more people took Zimhigh than we thought, for reasons that we were not really expecting. So since you all have heard all of this and got an even more in-depth comparison, why don't you guys throw in the chat, like, if you could pick any one of these for no charge, which one would you carry? And if you have strong opinions about it, why would you pick that one? Or you can come off mute and talk about it.
This is Shirley. I think I would probably take the Cloxado. I think that's how you say it.
Cloxado, yeah.
Cloxado, only because it's a higher milligram. And the reason why I say that is, in this area, I've seen overdoses where they've had to use multiple of the 4 milligram that police officers carry, and then still not being able to get people to respond.
Not seeing that recovery. Yeah. So that is an opinion we heard a lot, 8 milligrams, let's hit them with as much as we can at a time and just reverse that overdose as quick as possible.
I know the withdrawal is immediate, like some people get violently sick from that, but I guess to me, I'd rather see you alive throwing up than us calling the coroner to come and get you, because some of the stuff that's around here right now is really, really, really bad stuff, and the overdose rate is going up.
Yeah, and that's what we heard a lot. One of my colleagues at CORE said that he thought it was going to be all Cloxado. Everybody was going to want Cloxado because we're Americans, and 8 milligrams is better than 4 milligrams. And that it's the nasal spray, and we did hear that a lot, right? Like, the people, 4 milligrams is not enough, let's use more. But surprisingly, there were people that came down on the other side of it. And it was interesting. I helped do the trainings and everything. And it was interesting to watch people kind of talk through what they were thinking. And and how they were picking the product, but we definitely did hear that a lot. And we even there was 2 separate groups of law enforcement officials who came and did the training and hadn't heard of Kloxxado or Zimhai. And when we were talking to them about withdrawal and that kind of thing, in 2 separate instances, one police officer said, well, I don't care if they're puking. Well, that is a mentality that you can have. So I'm looking to see, people are more familiar with Narcan. Yes, that is absolutely something we hear. One person said, like, I'm going to go with the OG and picked the Narcan just because it was what they knew. Caitlin says people are saying that 4 milligrams is not enough and it's not bringing people back. Yeah, that is what we're hearing.
I don't know how to raise my hand.
Go ahead.
Can you all hear me?
Yep.
I worked at the Hope Center, and we had a lot of incidents like this. And I feel like a lot of people would hit them with 2 or 3, but they never gave it time. So they said they needed 2 or 3. Whereas I would hit them with 1 and wait a minute. And most of the time people would come from the 1. It's just no one ever gave it time because they were scared, and they'd hit them with 1, wait 12 seconds and hit them with another. And it's like, well, look, it took 2 to get them out.
Yeah.
So I don't know.
Yeah, thank you for sharing that, because that is something that a lot of the harm reduction people who are pushing back on these higher doses are saying, that you have to give it time to work, and that if you're giving 2-3 doses all in a minute, that is similar to giving 8 milligrams. And it doesn't necessarily mean that you needed that much. It just means you gave a lot before it had a chance to work. And I think it's kind of a self-perpetuating cycle, right? We're hearing, oh, the drugs are more potent. Oh, there's more fentanyl in the drugs. It's harder to reverse overdoses. And so people are getting more panicked, understandably, because they don't want to risk not giving enough. So we know people are giving more doses, but we don't know exactly why, and we don't know exactly how that's working out. So that is interesting that waiting that 2 to 3 minutes has been sufficient in a lot of cases with the 4 milligrams. Does anybody want to advocate for Zimhai here, a high dose in an injectable format? Probably let my bias show a little bit, because this is not one that I would want to use.
I have a question though about that. Like,
Yeah.
IM is going to take longer though, right?
It's a similar onset for all of them. The nasal spray takes a little bit to absorb, but generally 2 to 3 minutes is what we say, whether IM, intranasal, or IV. The IV is obviously going to be the fastest, but it's
I was just
slower
thinking, like,
to find the
nasally,
veins.
like it would absorb a lot quicker into the system, but
Yeah.
Okay.
Yeah, it's similar. It absorbs better IM. So like that, like I think I said last week, that 5 milligrams is actually going to give you more naloxone ultimately than the 8 milligrams is, because it is a more fully absorbed IM than it is intranasally. Yeah, so John and Whitney both are on the anti-needle train. The Zimhai gets injected, the recommendation is in the outer thigh. So you can do it through clothes, so you don't have to like take the person's pants off, but it does go in that outer thigh. Amy says, I'd carry the Zimhai, but I'm a diabetic and needles don't bother me. Yep. So that is one that we heard at the state fair. People said like, oh, I don't care about needles because I'm a diabetic, or because I carry an EpiPen, or whatever. The other interesting thing that shocked us, because we thought everybody was going to be in the like, I don't like needles, I'm not doing this category. People said they wanted to do the Zimhai because they didn't want to get near people's faces, that the idea of putting something in somebody's nose was less pleasant to them than the idea of injecting something in somebody's thigh. They thought, this is quick and easy, and I don't have to get near people's faces. So I don't know if that is an artifact of COVID, right? Like we've all stopped blowing out candles on birthday cakes and all that. And now people are thinking they don't want to be near nasal secretions. But a lot of people said, you know, I'd much rather do a injectable than get up near somebody's face that's overdosing. So there's a lot of debate right now. It'll be interesting to see kind of how this all shakes out and which products rise to the top. Yeah, Amy says they've heard they're marketing Zimhai as more effective for fentanyl. Yeah, that's definitely, like I said, that's definitely where they're pushing. Kloxxado, interestingly, is not, I mean, they will say they're the highest dose on the market, but they are not as in your face about saying like you need 8 milligrams to reverse a fentanyl overdose, or you know, this is, they don't try to imply that Narcan is not going to work, kind of the way Zimhai is pushing in their marketing. And like I said, I don't know that we have any evidence that that's true, that 4 milligrams is not enough. In the pre-fentanyl days, 0.4 milligrams in the intramuscularly was enough, and 2 milligrams in the nasal cavity was enough. So a lot of the harm reduction people are saying like, we've seen this before. We've seen high dose opioids before, and we've reversed them just fine. So maybe the idea of fentanyl poisoning from airborne, yeah, that could be that people don't want to be near the place where there might be fentanyl. Yes, we've heard that also as an excuse for not carrying naloxone, that they don't want to touch somebody that has overdosed from fentanyl for fear of secondary exposure, which is a bad excuse because it is highly unlikely. All right, any other thoughts or questions on kind of the dosing and the products? If we get a paper out from this state fair study, I will have John put it in the newsletter and you all can read it. I don't know when that will be, but we're working on it. And we would like to repeat it with other populations. This was just folks at the state fair. And so this was not any specific. We would like to try to aim for a harm reduction population and see if they have different opinions than the general population does in terms of product preferences. So the last question that we received was, what trends have you seen in naloxone in the last 2 years? Are people more receptive? Is there less stigma? And this is one where I definitely want to hear from everybody on the call, because I know you guys have been out in the communities in various ways over probably more than the last 2 years. Personally, I will say it's hard for me to put my finger on this because I have been involved with the study for the last 2 years. Going back to before I was involved in the study, I probably had different encounters with people, right? People now kind of know that I'm the opioid safety girl, and they're not going to tell me that they don't believe in naloxone or that they're not receptive to naloxone. So I don't hear as much stigma, and I don't hear as much pushback, but I think part of that might be because most people are non-confrontational and they know that I'm going to argue with them if they do push back. I will say the stigma that I see is changing from what I used to see. I think, unfortunately, because we're losing so many people now, we had over 100,000 drug overdose deaths last year. It is a lot harder for people other people who use drugs. Everybody knows somebody that has been affected by this, whether it's, oh, I work with somebody whose relative died, or there's a family at my church that lost their son, or whatever. Everybody has kind of been affected by this. And so you don't see sort of the dismissal as often of, this isn't a problem in my life. This isn't something that happens to people like me, or whatever people used to say. I hear a lot less kind of grotesque comments about opioid overdose. But I think that as a result, the people who still have that stigma have shifted their mentality to different ways. They're looking to rationalize pushing this out of their vision. So we see a lot more like weird reasons when we approach people and say, hey, we'd like to distribute naloxone on your campus or in your organization or at your event, we see them kind of twisting themselves into pretzels to find reasons that they're not going to do it, without saying like, I just don't want to. So they'll say things like, oh, well, there's liability issues, or one time they said, well, we've heard that if you reverse an overdose and the person doesn't get extra help, they might die later on, and we don't want to deal with that. And I was kind of like, well, you'd rather they die immediately instead of later. It was very confusing, but it was obviously an attempt to push back without saying, this just isn't something we want to deal with. So I hope people are actually more receptive and that there is less stigma, but I think we still have some work to do to get people over that last hurdle of stigma. So I'm looking at the chat. Caitlin says, I think people are a little more receptive. People get offended that they're trying to offer naloxone to them. Yeah. Yeah, it was interesting at the state fair. I was surprised we didn't get as many offended people as I feel like I have in the past. We actually, on the good news side of things, we had 11 days at the state fair, and we had originally set out to train 400 people. And we went back to the IRB 4 days in and said, we would like to increase our recruitment goal because we were going to hit 400 people in like less than a week, and we didn't want to just shut it down. So we wound up with almost 700 doses just with the study. They also were distributing doses for people that didn't want to take the survey and be part of the study. So people were a lot more receptive there than we thought they were going to be. Jacob says, thinks people are starting to understand that this is saving lives. Dr. Nichols asks, are people who use methamphetamine or cocaine receptive to naloxone? I think that is the next hurdle, right? That is kind of the current education point. This might be something other folks, maybe some of the Voices of Hope people could talk about, because I have not interacted much with people who use methamphetamine or cocaine. I don't know if other people have experience. Amy says, a friend who works retail mentioned a free training because he works with the public, and his wife was upset because she didn't understand why he would want to go out of his way to try to save someone. Yeah, that like I said, it's been a while since I've heard that, but that is definitely something that used to be far more prevalent. Luckily, like I said, I think now people are more in the better safe than sorry, and that might be partly because of the myth of passive fentanyl exposure. People don't know if it's going to happen to them, and that's why they want to carry naloxone. But if it gets them willing to do it, that's a good thing. Yeah, Dr. Nichols says basic CPR BLS incorporates naloxone chaining. Yeah, and the non-healthcare professional version of that too, the Heart Saver CPR training also includes, the first aid section includes a section on naloxone now as a potential emergency that you might have to respond to. So it is definitely becoming more common. And he says high school freshman asked over the summer if she could be trained. That's great. Oh, and the school nurse encourages it as well. So that's awesome. I found that the high schoolers and college students that I have talked to are way more aware and open-minded towards this than a lot of the adults. I mean, college students are adults, but a lot of the older adults that I talk to. I will also say that the younger participants at the state fair were far more engaged in like asking questions about like which product and what will happen and what's the evidence, and that really gave me hope for the future. Some of our older folks were just like, yeah, give me whatever. They didn't think about it or have any opinion on it, but the younger people were really eager to learn more. So John asks, can one of our peers present speak of clients with polydrug use that are scared of fentanyl that want naloxone? Which would be great. Anybody? So Molly says, we had a mass casualty event in Northern California where people thought they were smoking meth and it was laced with fentanyl. And that has, ever since then, people have been asking for extra naloxone. Yeah, I think it only takes like one experience or one story to really raise people's awareness. We talked to the pharmacy students actually a couple last week, and their professor mentioned, hey, there's an Adderall shortage, and I know that affects college students. So if you are getting Adderall from a source that is not the pharmacy, and you could see people kind of sitting up and taking notice, right? If you connect it to a risk that they know they might partake in, then that helps raise awareness. So Thomas asks, what about separate teams, maybe trained volunteers going to EMS calls to follow up with bystanders and help with EMS capacity? Yeah, so that is definitely something that is a model EMS departments are using. Obviously, it's a staffing issue, right? They have to have somebody that they can take with them. But we have seen models where they bring a social worker. We have seen models where they bring the peer support person with them to the overdose call. And we don't have papers on it yet, but we do have lots of anecdotal evidence that that is an effective way to reach people. And so EMS deals with the medical part of it. And then you've got the social worker or the peer support specialist or another type of volunteer there to talk with family and friends and kind of address here are some resources for preventing overdoses in the future. Here are some resources for treatment if the patient's interested in that. Those are all models that places use. I think that is a growing trend in both emergency response and in law enforcement response, is to try to bring trained people who can address the big picture situation as opposed to just the immediate emergency. And thinking about staying after EMS is left. Yeah, so that's the idea, right? EMS gets the patient, takes them on, and the other person stays and does kind of the follow-up care piece of it. And then we also have kind of our quick response teams, right, where EMS takes the patient, takes them to the hospital, and then immediately reports to a team of people who are dispatched the next day or the later that day to go to the person's home and say, hey, here are some resources for you. I apologize if you all can hear my dog freaking out. I don't know what her problem is, but yeah, Lexington has a community paramedicine team that does that. Yep. A lot of our wave 1 counties got QRTs or some model like that set up. And John says a social worker could probably help with secondary trauma as well. Yeah, so just that skill set is so needed at the site of any emergency. They can come and really connect people to whatever the next thing they need is.